Welcome, Tim.
Okay, thanks for inviting me. As you've already said, there's lots of sphincters prostheses we can talk about. I'm mainly going to talk about penile prostheses and the artificial urinary sphincter. I've been asked to talk about centralisation and surgical volume. This is all about optimising surgical results, and it's clearly, there's lots of people and individuals that need to have good results, not least the patient and the surgeon themselves, and we're being encouraged to collect data, so data from the patient telling us how well we're doing, and data from the surgeon informing his peer groups and others how well they're doing. And by centralising and getting volumes through, hopefully complications will be reduced, and what complications there are, they'll be treated better than if they're managed by people doing relatively few. And obviously, if you're going to concentrate procedures into a big centre, then you have the benefit of training the multidisciplinary team rather than just having a different nurse in there every time you do the odd one. And there's spin-offs for the people who have to buy the devices and provide the services, both in terms of efficiency and targets. And obviously it offers an opportunity for benchmarking and trials. So this is Steve Wilson, who's since retired, but basically taught most of the surgical andrologists in the audience today surgical andrology. And you'll notice he's got a small button there. And even in his hands, this sort of thing does happen. I don't know if you can read it, but it says, Rodin's, the leg over suddenly became just the kiss. So just have to be wary of what you're doing. And previous speaker mentioned Brantley Scott, and here he is saying 30 years of prosthetic experience have shown several disadvantages to the original surgical techniques. And in fact, the plane that he crashed was one he built himself, so he has some responsibility for his own demise. So this is a ladder of surgical learning, if you like, or all learning, where you start off with unconscious incompetence and move through gradually into unconscious competence. And you only get that through practice. You can only get practice if you're doing a lot of it. So this underpins the philosophy of not only doing a lot of procedures per surgeon, but that surgeon doing them in one unit as opposed to many units. So getting on to some data. This is HES data from 2009-2010, and this is the HRG code for penile prostheses. And in this period, 263 penile implants, that's all types of implants, were put in 35 NHS trusts. And the main ones, that is those with those of 10 or more, are listed. So University College Hospital, not unsurprisingly, 93. Next one is us in Leicester at 21. There are 28 NHS trusts doing 6 or less. One might reasonably argue whether this is a good use of resources.
Okay, fine. That way. It's on there as well.
Yeah, okay, that's fine. This is a BAUS audit that I did in 2002, 2004. So over that period, there were 420 patients of penile prostheses of all sorts. 315 were primary implants, 105 were revisions, 84% were inflatables. So quite a significant number then of semi-rigid devices. Again, 75 implanters, only 3 surgeons doing more than 20. So again, one has to ask whether that's a reasonable distribution of surgery throughout the UK for this type of procedure. This is HES data from 2013-2014, and you can see that UC are leaping ahead with 139. We were there with about 23, and there are others. And once again, there are 23 trusts with 9 or less, and 12 trusts with 2 or less. So this doesn't really represent, I don't think, concentration of resources either for hospitals or surgeons, and it's something we need to think about. And if you look at surgical volume and volume through hospitals, the literature across all surgical specialties supports the concepts of high volume activity at a centre of excellence. Now, to get level 1 data on this is very difficult because it tends to be cohort studies, but nevertheless, across all the papers that have been written, there is more support for doing difficult surgery or specialist surgery in big centres by a small number of surgeons. So when you go to the literature and look at papers written by urologists, particularly about prosthetic urology, this one stands out. This is by Gerard Henry, who actually was a colleague of Steve Wilson, learnt his prosthetic surgery with him, and this is an interesting paper from 2009. And what Gerard did was he described an outcome analysis of 57 penile prostheses implanted by a practice group of 10 urologists who worked opposite him between 2001 and 2004. And in 2004-2005, he did 57 implants himself, so much shorter time, but similar numbers. And the outcome was that him, being the explant implanter versus a group of urologists, got a greater length of the cylinders, 2 centimetres, at that sort of level of significance. He was doing the operation quicker at that level of significance, and he had no revisions in his group versus 8 revisions in the group of urologists. Similarly, the difference was shown up in the type of implants he put in, which were inflatables in all cases, whereas only 51% of the ones put in by the group of urologists were inflatable. So it shows a huge difference in quality and outcome as related to penile prosthesis. It's the only one I can really find in the literature which supports that. So where does that come to? So this is something I'm just offering off the top of my head, so you're free to disagree with it, but I think there is a degree of truth to it. I think when you look at the numbers and where the work is being done, you can probably justify concentrating penile surgery in about 10 to 12 centres, and you might reasonably ally that to penile surgery generally, so that might be in a centre that does penile cancer and urethroplasties as well. Clearly, the first implant gives the best results. You probably should be doing 15 to 20 primary implants a year, and if you're going to do salvage surgery, you probably should be doing 5 to 10, and everything should go into the BAUS data and audit. I just looked at my results for 13-14. We put in 31 penile implants, 28 were 3 pieces, 21 were primary, 7 were salvage, 3 semi-rigid. And I've put up what we did sphincter-wise, not sling-wise, but just sphincters. Not a huge number, but keeps it in the top 10. And when you combine the two, it gives me a prosthetic implant of about 42, which is pretty reasonable when that's considered outside London. And I would argue that by putting the peniles in with the artificial urinary sphincters, you're using very similar techniques and the team to do it with. So we've already seen pictures of that young man. So talking about artificial urinary sphincters, again I went to HES data. This is 2009, 2010, and there's the HRG code. This is just for the UK, so 225 sphincters put in men in 32 NHS trusts. Similar sort of distribution, University College, big numbers, but Bristol, reasonable numbers, Birmingham coming up. 24 NHS 6 or less, and only 9 sphincters in women, 2 of those at UC. I also did an audit of sphincter usage in BAUS membership and looked at the years 93 to 2003, 677 implants, 391 were primary, 286 were revision, 67 surgeons. There was only 6 surgeons doing more than 10. So similar sort of story to sphincters. This is more recent data, 13 and 14 UK data, 362 sphincters. Again, UC up at 67. Birmingham now coming ahead with Zaki Al-Muller, and Bristol coming ahead with Hashim and Paul. So those are the big centres, or centres more than 10, but 35 trusts, 9 or less, of which 15 are doing 2 or less. Interestingly, when you look at the world literature, you look at prosthetic urologists and what they do, so 9 out of 10 prosthetic urologists worldwide will do less than 5 sphincters. you have to ask whether that's a good way of managing that resource or not. So if you look at the sphincters alongside the penile prosthesis, I would again suggest that you're probably looking at 10 to 12 centres. I would make a plea for prosthetic urologists doing not only peniles but sphincters as well, and male incontinence, and probably running it through a centre of penile cancer and urethroplasty. That would all make logical sense, but I appreciate it doesn't necessarily make political sense. There's a current a study that Paul Abrams and Hashim's doing called the Master Study, which is a prospective randomised controlled trial of male advanced sling versus AMS 800, and that's recruiting reasonably well. So maybe a couple of years will give us some answers as to where we are with sphincters and slings with regard to moderate incontinence. There was one paper on artificial urinary sphincters and surgical volume more recently than Gerard's paper, and this comes from European Urology 2011. And this is a fascinating paper. It's an American study where they reviewed 65,000 males implanted with artificial urinary sphincters between 1988 and 2008, and they tried to look at the learning curve for the sphincter procedure, and they used some rather strange statistics which I don't pretend to understand, but essentially what they did was they used an indexed procedure of the first re-implant from when the patient was implanted, and looked at surgeon experience, applied some statistics to that, and what they essentially found was for surgeons doing 5 procedures or less, the risk of salvage surgery was 24% in the first 5 years, but if the surgeon had done at least 100 prior sphincters, that went down to 18.1, and if they'd done 200 prior sphincters, essentially the risk halved. So basically what the study showed was the more you did, so that when you get up into 100, 200, you're significantly reducing the revision rate, and he concluded by saying that only 30% of the patients having a sphincter were being seen by surgeons who'd done significant numbers. So essentially the figures would suggest that we are doing a lot of prosthetic work in small centres by surgeons doing 1s and 2s, and I would suggest to you in the current climate that is both risky for the surgeon and not a good use of resources, and perhaps both FNUU and the andrology section should think very carefully about making some recommendations for where this type of surgery should be done. Thank you.
Thanks very much, Tim. I was particularly interested in seeing that if you have a high volume surgeon do your penile prosthesis, you get 2 centimetres extra length. I think it's well worth considering. 2 centimetres may be important. On a more serious note, Tim, is there any sort of political moves in relation to specialist commissioning within the NHS, or anything that we as the sections need to know about in relation to prosthetic surgery that's likely to bring about centres dealing with this work?
I think it will follow on from cancer work, won't it? And where you have one hypothesis for one subspecialty, it's very difficult not to then advance it for another. So if you're basically saying you've got to be doing 50 robotic prostatectomies a year to get your ticket to drive the robot, it would be very hypocritical to say you can do 2 penile implants and 1 sphincter a year. These are very costly devices. These are people who've already usually been wrecked by another surgeon, usually the oncologist, and they want to get a good outcome, and it does not make sense for people to be doing 1s and 2s. The only model that makes sense for that is if people wish to do them in their own hospital, then you need a mentor surgeon going out to do that with them. But the weakness of that is, of course, he's not going to take his team with him, and it's the preoperative assessment and it's the post-operative care which are just as important as the surgery. You don't get that with the visiting surgeon, I don't think. So I would make a plea that we need to be sensible about this. And just like Tony Mundy might turn around and say all posterior urethral disruption injuries should go to UC, maybe we should just look at people doing reasonable numbers and saying those should be the centres. And if you ally them to penile reconstruction generally, that all makes quite good sense.
Any questions from the audience on this topic?
I've just got a comment about, I think it's all going to be under the spotlight from NHS England with regards to centres doing penile prosthesis, and I think we've got to be honest with ourselves and admit that, you know, people doing 1s and 2s is probably a bit archaic now, and we should designate about 12 centres nationally. But the question is, you know, what is a minimum number? You know, how many should people be doing?
Yeah, well, the other argument about a prosthetic urologist, of course, there was a vogue in the States for people who were wrecked by radical prostatectomy putting in a penile and a sphincter at the same time, or a penile and a sling at the same time, and clearly some of the high implanters over there still do that, and if you do it through a scrotal incision you can get both in through one incision, and I've certainly done that, but you wouldn't expect anybody other than a very major implanter to be doing that in the UK. So, but that's the role for a prosthetic urologist.
Thanks very much, Tim.